Welcome to Eminent Psychotherapists Revealed. This is the fifth in our series, and I am very pleased to have Nancy McWilliams join us. Nancy is a professor at the Graduate School of Applied Professional Psychology at Rutgers, and she practices in Lambertville, New Jersey. She's the author of Psychoanalytic Diagnosis that came out in 1994, Psychoanalytic Case Formulation, Psychoanalytic Psychotherapy, and her new book, Psychoanalytic Supervision, is coming out shortly, which I'm looking forward to reading when it comes out. I am so happy to have you with us, Nancy. Nancy is someone who I identify so closely with because she is not only a wonderful writer about our work, but she also is a preeminent clinician. And when you read about the way she practices and listen to the way she talks, it often just stirs my heart and makes me cry. So without any further ado, I'd like to introduce Michael and Michael Albert, our co-host, and Barbara Ingram, our co-host. So without any further ado, let's start our discussion.
Okay, I'm going to ask the first question, and I just want to say how happy I am to be here with you, Nancy, and colleagues. And I was privileged to read an essay that you wrote, Finding the Other in the Self, that I know was also a presentation. There's so much about that that I loved. But my thought is, could you talk some bit about how you explain the construct of respect? Because I've never heard, we learn things like empathy, positive regard, respect, and this and that, but I've never seen that construct explained so well.
Oh, well, thank you. I had a student who wanted to do a doctoral dissertation on the concept of respect for the patient. And he did a lit search, and he came up, of course, with a gazillion articles about empathy and 5 about respect. And it made him curious about how therapists think about respect. And he did a qualitative doctorate, interviewed, I think, 10 experienced therapists in the community and asked them about respect for the patient. And most of them said something like, I work at that. It's a discipline. It's usually easy to feel empathy for a patient if you know what they've been through and what their family was like and what their travails have been. But respect is harder. You have to work at it. And they named groups of people like pedophiles or marital cheaters or compulsive gamblers, where they had a lot of empathy for the person, but it was hard to respect them based on their behavior. And it just started me thinking about what an important attitude respect is. I suspect unconditional positive regard is about the closest thing in the humanistic literature to that. It doesn't quite capture the edge of it that involves wanting to learn from the patient. What I came to was that respect is a kind of looking up at the patient. It's not admiring them necessarily, but it's expecting to learn something. They have something to teach you. Mm-hmm. And I think it's a critical attitude for therapists to take that respectful position. I've always curious, as therapists, we don't get too much chance to watch how other therapists actually work. But I enjoy watching videotapes of therapists. And one person I was really interested to watch was Otto Kernberg, because when he talks about patients, it can sound quite harsh. And it's true that he's not all warm and fuzzy. But if you listen to how he conducts an interview, there's just enormous, unflagging respect for the patient that comes through. And that's how he can make a good connection and manage to say rather difficult things to rather difficult people. You can see this in operation when you watch good therapists. My husband, Michael Garrett, who you might want to have on the show at some point, has worked with psychotic patients for 35 years and put out a book a couple of years ago on integrating cognitive behavioral therapy with Kleinian kind of psychoanalytic therapy. He's worked for 35 or more years with crazy people, schizophrenic people among the urban poor in a hospital, public hospital setting. And that's the attitude that he heals them with. I mean, he's had some extraordinary positive effects on people who were thought to be hopeless. And because he expects to learn from them.
Yeah, that's fascinating. My daughter Elizabeth works in a psychiatric hospital with severely mentally ill in Boston, and I think she has the same kind of natural proclivity to just totally like get into and respect them. And the stories she tells me, just they're so heartwarming. They just bring tears to my eyes.
Yeah.
We will have him on. That'll be great.
You'll enjoy him.
So Nancy, we share a lot of common interest. Your interest in working with the most challenging people with characterological or personality dysfunction, as I like to call it, has been remarkable. And I learned so much from reading your books about how to work in that zone. And you have certainly a psychoanalytic kind of perspective, but you also seem to integrate a lot of other kinds of theoretical perspectives into your work. Can you talk a little bit about what you think the essence of working in the area of personality disorders is for me and for the people watching? Because I think they're always so challenging for us, and respect is a big part of that. And what's like, I know that you could probably talk for 20 hours about this, but if you were to kind of distill, like, what do you think we need when we work with people with personality dysfunction or chronic patterns of self-defeating, self-sabotaging behavior?
Well, let me first talk about the therapist. I think we need to be really clear about our own boundaries and the conditions under which we work, and be able to set limits on people and tolerate their being enraged about that. And in general, tolerate very powerful affect in the patient and in ourselves. And for some people, it's just not their favorite population to work with severely personality disordered people. But I kind of like the intensity. And I think what you're doing when you make a relationship with a person who's trying to rewrite the core story, whether you call it internalized object relations or core schemas or inner working models, there are a gazillion different terms for the idea that we all have a story about ourselves. And if our story is adaptive to our life later, nobody questions the story, whether it's a crazy story or not. But some people's stories are very maladaptive. If what you learned as a child is that you can't trust anybody and the world is a jungle and you better take care of number one, and you try to live your life that way, you're not going to have a very good life. So you need to get into a relationship where not only you have your mind encouraged to rethink this idea, but you need to be in a connection with somebody where you see it in real time, that they are behaving in a way that is new to you. There's a group in Germany that did this wonderful research on, they took real patients and so-called treatment-resistant patients who'd flunked 2 previous therapies, and they paired them with experienced therapists of different theoretical orientations, and they videoed them, and they analyzed the facial affect. And what they found was that in the therapies where both the therapist and the patient agreed there'd been significant progress, the therapist was showing what the researchers called abnormal affect, meaning in normal affect, you tend to match. You know, your teenage kid comes in and talks to you like this, and within a millisecond, you're talking to them like this. But our training allows us to take an angry patient, and on our face, instead of counter anger, we'll show curiosity. I mean, why, that's interesting that you're angry. Or they'll come in with terrible shame, and we may show anger that someone shamed them, rather than joining them in shame or having contempt, which is kind of the flip side of shame. And they're learning completely non-verbally. There's a different way to feel about things. And I think that's why psychotherapy is exhausting too, because it isn't a normal way to relate. It becomes normal to us, but to take in all kinds of toxic affect and give back something a little bit different. It looks like Beatrice Beebe's work with mothers trying to help their kids move a little bit ahead. It's very tiring work, but I think that's part of the essence of what we do.
So you're talking about what I would call co-regulating and metabolizing affects that people don't have the mentalization capacity to metabolize.
Couldn't have said it better. Yep. And I do think it has to be through a relationship. We have a lot of.
It's not going to be done on a computer ever, you don't think?
I can't imagine a world in which you go to a computer and it actually gives you psychotherapy.
How are you going to put a soul in a computer? A heart in a
right.
computer, the autonomic nervous system. We don't have, and that's going to be a trip.
Yep.
But
How
go ahead, Michael.
Ask if following up on this. So given that you're going to be relating to them in a different way, which can be upsetting for them because they're used to in other words, they're used to having people relate in a certain way to them. Mm-hmm. Suddenly, you're asking questions about things that they haven't thought about or make them uncomfortable, but you're not reacting to their anger with anger back. You're saying, "Wow, that looks like something really was upsetting about that." How do you prepare them for this so that rather than having to kind of go through a whole series of battles or of alterations when you keep trying to do this, how do you teach them? You lay it out and explain it, or do you just let it evolve?
I pretty much let it evolve. I ask them what they see that they want to work on, how they would like to be different. And I say that for a long time, I'm going to be trying to learn from them what their life is like. And I will ask questions when I don't understand something. And the more freely they can talk, the better. This is where the analyst in me comes out. The more you can say everything, the better. And if you find yourself having trouble doing that, that's what we'll get interested in. We'll get interested in the fact that you want to make certain kinds of changes and you run into an internal resistance to making those changes. That's what we'll struggle with, and it's not going to be easy. It's not a tea party.
Well, that's the way you answer that question it epitomizes something I want to ask you about. You don't use psychobabble. You seem to use English in very clear words. How did you train yourself to avoid the field and do this?
A couple of things. I loved reading Freud. People don't read Freud much anymore, but one of the reasons Freud was such a great propagandist for himself was that he was a terrific writer and he spoke ordinary language, especially if you happen to know German, which I don't. But the id, ego, and superego is just the I, or the it, and the I, and the above I. And he brought everything down to comprehensible daily life things, slips and dreams and jokes. And he was a great communicator. And that was my model. I was very surprised when I found out that most psychoanalysts didn't follow his example. Theodore Reich was another important influence on me, and he was a good popularizer. But in addition to that, I had really, really good high school teachers. One, my Latin teacher, who had been the English composition teacher of John Updike before she had me for classics. And my English teacher who had us write a theme every Friday. And then on Monday would, read the themes. Every Friday he'd put a title on the board. It could be anything. And we had to write a theme about it in 45 minutes. And then he gave us feedback on Monday about how it could have been clearer, what's a more elegant way to say this. I learned grammar, and I love grammar. And I always had a suspicion in college that I was getting about 1 grade more than I deserved because I wrote well. I wasn't so sure I always knew the stuff or thought well, but I had really good influences in that direction. And it's always bothered me that psychoanalysts keep making up different terms that, if we want to progress as a field, both within psychoanalysis and between psychoanalysis and all kinds of other ways of thinking about the human animal, we have to have some amount of common language. So also, I'm a teacher. I mean, I often think I'm a somewhat better teacher than I am a therapist, because as a therapist, I get so interested in certain things, I can easily intellectualize stuff rather than follow it into the affect where it needs to go. But I've been teaching since 1970, and I am always on the lookout for how would I explain that to somebody who isn't already socialized into this kind of language. So.
I just want to go back to before when we were talking about computers have a soul. I didn't take the first question that way. I want to ask something very mundane. How do you think Zoom is working for doing therapy? Like a lot of people, of course, during the pandemic made the best of it, but I know a lot of people want to stay on Zoom, therapists and clients.
Yeah.
So how do you feel about your approach and the whole relationship essence? Does it kind of translate to the Zoom?
I have never done a therapy which I started on Zoom. When the pandemic came, my patients, of course, shifted to Zoom, but they had been in my office. I had a sense of their body language. My preference when I'm doing clinical work is to do it by phone, because there's something about the way the screen possesses you, the distractions of it, the small technical glitches where the words don't quite go with the music, and getting distracted by my own image. When I'm trying to just help a client, I don't want to be thinking, ooh, you look old, you shouldn't wear that color. So Zoom distracts me. And what I missed when I shifted to Zoom was a certain amount of space for reverie. When you're sitting across from somebody, you can look up at the ceiling, you can think a little bit, you can shift in your chair, you can have a sense of their own proprioception. And I miss that in Zoom. On the other hand, I have gotten used to it, and there are some things I like about it. It's convenient. I have a home office anyway, so for me, the level of convenience is not so radically different as it is for some therapists who have to, commute to an office. They're finding that Zooming at home is probably going to save them a lot of rent. But I like seeing my patients' homes. I like it, there's always a cat that walks in front of the screen. I see their pets. Sometimes I see their children. I don't feel nearly as safe in terms of the confidentiality when I'm working on Zoom, depending on where they are. But there are some features I've kind of enjoyed. So the jury's still out as far as I'm concerned. I prefer in person.
It's a mixed bag.
Yeah, like
Yeah.
most things.
But I want to give you a tip, a Zoom tip. You can turn off your face view so you don't get to see yourself. So I just want to throw that out.
It probably says something about my personality that I don't want to do that.
I want to add something too, because I think the tremendous thing that it adds for the therapist being in Zoom is you get immediate supervision. If you watch your own face,
Yeah,
you're amazed by all the things that are going on that you're unaware of, all the
yeah,
feelings that, you know, you just haven't entered consciousness, but there they are sitting on your face. And when you see them, it can be quite dramatic.
yeah.
And, I remember working really hard with a patient, and just I thought this was the most stubborn, resistant patient I'd ever had. And I happened to look over at myself, and I looked like this. And I said, oh my God, that poor old guy, he looks so tired. And immediately I smiled, I looked back at the patient, and he became a piece of cake.
Huh.
It's really powerful. I mean, how,
Yeah.
our headspace can distort what's going on.
Yeah.
So Nancy, when you gave your talk at CEPI years ago that I thought was very powerful for me, you spoke to me. I felt like you were locating me because you spoke about what it's like to be a clinician in our culture, and a couple of things that I remember about that talk and about that paper were how devalued we often are by the insurance companies, and like we're just technicians and so forth. But you talked about how sometimes we're the only person that's between our patient and no human connection at all. And I have people like that. Sometimes I am the only human connection and it's so fragile and it's so heavy sometimes. Can you talk a little bit more about your personal experience doing this work over the decades? Like, what can you tell us and our viewers about the journey of doing something so solitary and so often life-saving, what it's like?
Well, I think I'm lucky. I'm just very genuinely interested in individual differences of any kind, not just how a more hysterical person differs from a more obsessional one, but if you're a twin, if you're an adoptee, if you come from Guam, if you were raised in a religion I'm not familiar with, I just am.
But I was more interested in how you can help us with how do you deal with those patients that are so out of connection, and you have the responsibility, and they're often suicidal, or they're often, sometimes I worry about whether they're going to go out and do a postal thing or something like that. How do you manage that, being the only person in your own world with that individual? How do you do that?
I suffer with it.
Thank you.
I worry, I worry about them. I remember I saw Steve Mitchell on a panel one time, and he was talking about his work with an extremely difficult, withdrawn female patient. And I can't remember what had just transpired between them, but it involved a vacation that she was unhappy about. And he said, I'm glad to see you. I was a little worried about you. And she said, you worry about me? And he said, yeah, that's what therapists do. We're professional worriers.
Yeah.
We worry about people. And I have
some more than others.
Faith about this, that the patient feels your attachment to them. They feel your worry. They feel that you keep them in your mind, and nobody else is keeping that person in their mind. So I feel a burden to it. It's kind of like being a mother of a somewhat fragile infant 24/7. Not that people are infants, but it's the same feeling of responsibility.
Yeah. Thank you.
How do you, how do you use that concern to help them? How do you make sure they get it, that they understand, and what is it like for them to have you concerned? How do you work with those elements?
I don't push it on them in any way, because I think some people have had such a hard life that if they really took in that I am carrying this kind of love for them, it would be overwhelmingly upsetting. You know, there are people who can't bear that because it calls their attention to the fact that their life has been completely devoid of this kind of connection.
Yeah.
So I'm a little bit reluctant to try to show them how much I care. I remember what they tell me. I ask them about things. I don't criticize them for the most part. And I play a little bit to whatever extent I can enjoy them. If there's some way the two of us can find metaphors or some playgrounds of the soul that we can get into together, I think you don't have to find a way to communicate that. I think if it's true, it will come through.
I asked because obviously it's something I'm interested in, but as you begin to develop some feeling about them as to what they're about, and you physically feel it, it's on your face if you see yourself on the screen. And do you notice that do you ask what they see on your face, or what it's like to be with someone looking at them as you're looking at them, or anything like that?
Sometimes I've said that, or sometimes I see a shift in their face and I say, "What are you reacting to?" And they often come up with, "Well, I thought you frowned there, or you look bored,
Yeah.
or you looked away. What does that mean?"
Yeah.
And then we're off and running with
Yes.
what's going on.
Rich fodder.
Yeah, absolutely. I mean, I love this work, but you know, when you and I were talking before we were actually on the show, and we were talking about how much we love the work, it's also it has its downside, you know, and part of it is just the amount of responsibility that you feel for people, keeping people alive to whatever extent we can do that. Giving people somebody who hears the human being that's striving toward health, even from the craziest place.
Yeah.
I
Well,
want to bring.
sorry. Go ahead.
No, I want to bring up the topic of supervision, since you mentioned that a book is coming out in the fall, and I teach in a university where students are out in practicum, and then they meet and together, and we talk about their supervisory experiences. So I'd love to hear, and also you're supervising people in a very challenging orientation, way of working where they have to use themselves as well as their academic. So I'd like to hear.
Well, I got interested in doing this book partly because a friend of mine started nagging me. My friend Malin Forrest started saying, you've been supervising for 50 years and all over the world, and this is true, and all different populations, from prisoners in Norway to a Zulu woman in South Africa. I do have a fair amount of experience now. So I began thinking about this, and like all my books, it had to cook for a few years before I had it kind of organized. And I was realizing that at least psychologists and psychiatrists, maybe to a small extent social workers as well, are getting a lot of pressure to be supervisors and to let other people do the actual therapy. And I don't like that development, but if that's going to happen, then we have to be sure we know something about how to supervise. APA is asking psychology programs to have courses in supervision. And as I looked at the way that APA has been construing what supervision is about, it tends to be about teaching techniques and developing competencies in a kind of stepwise way. And that just wasn't my experience of learning to supervise. It was much more about identifying with a person and that person's values, with finding how to integrate my personality with my work and develop my own version that's true to me of being a therapist. It wasn't really about skills training. It was about professional and personal growth. And I think the primary skill of a good supervisor is to make the supervisee feel safe enough to tell the truth about what they're doing and experiencing with the patient. And that's not always easy. It's a power relationship, especially if you're going to be an evaluative role toward them. And there's beginning to be some research asking supervisees about their experience, not just trying to figure out things to measure as competencies that increase. And supervisees are telling us that usually they don't tell everything to their supervisor. And often they find their supervisors are insensitive or unethical or sort of stupid about diversity issues that are important to them. So, again, we've got to start listening, not just trying to impose whatever is measurable onto an activity that we're defining from a position of, we're the ones who can define this, rather than asking therapists to tell us what's helpful to them.
One of our viewers, Denise, said that Celebrating the Other by Sampson, which was published in 1993. I'm not familiar with the book, can be related to the concept of respect for the patient. So that's might be an interesting.
Was that Harold Sampson?
Yeah.
Okay, so that's in the control mastery tradition then, right?
I'm not sure. I'm not familiar with the book.
Celebrating the Other.
Yes.
Thank you.
Thank you, Denise.
That's a good entry for a lot of things.
Yes.
I think that we want our patients to learn to celebrate themselves. The celebration rather than the condemnation or the avoidance is behind a lot of the pathology of the failure to celebrate. Failure to accept is a major issue.
I would say that's true for some patients, but I think for some patients, they have the opposite problem. It's defensive, but it's built into their character that they think they're wonderful and smarter than other people and entitled. And if they're suffering, somebody should fix it. And what's wrong with the world that, they're not the center of the world. And that's a very different thing to deal with. And I don't want to encourage them to celebrate themselves. I think I'd like to encourage them to celebrate a few other people who have to live with them.
So that's obviously that word kicks off different responses in different people. But I'm talking about celebrating. I don't know what the context was from the questioner, but the context that I'm thinking about is the have feelings about themselves that make them feel like they're part of a celebration. In other words, have very warm, caring, happy, tender feelings about themselves.
Yeah, you want people to
kind of a pardon?
Care for themselves. Yeah, you're talking about
right, that kind of a celebration.
Yeah, I think you only get that by internalizing that somebody cared for you. So I mean, that's what goes on in therapy.
It sure does. Yeah.
I have an academic question. I just want to raise the word borderline, which you write a lot about, and the distinction between the border, the BPD in DSM, and your view that any personality disorder can have borderline organization. I don't know if I'm getting the word
Yeah,
correctly.
and I know
but-
what's behind this question. Barbara and I are writing a chapter in a handbook of psychotherapy and personality disorder. So we want to pick your brain on this one.
Oh, okay.
Right. But you get a whole paragraph, by the way, your approach. And so
Well, don't
I'd like
call
to
it my
hear from-
approach, because what I have tried to do
course.
is integrate the mainstream of my way of thinking, which involves a whole bunch of people of somewhat different views within psychoanalysis. I never was interested in developing a McWilliams version of psychotherapy or understanding of people, but first of all, I don't use psychiatric terms in a disparaging way. I use them in a simply descriptive way. And as terms, get some history, they get associated with contempt and hatred, and hysterical used to be a fairly matter of fact.
Pejorative.
And now it's pejorative. But you can't keep changing the language all the time. So I kind of liked the idea of, I remember when we started really identifying that there was a group of patients that were too troubled to be considered just neurotic, but they weren't troubled enough to be psychotic. And they were on the borderline between neurotic and psychotic. And that's how the term arose. So the original concept is the one that I found clinically useful, which is on the whole dimension of, you can be a really healthy version of this personality, or you can be a schizophrenic version of this personality. Where are you at the more neurotic to healthy end, in which case you can kind of see what your internal conflict is and make an alliance with the therapist and understand the therapist is trying to do things in your interest, even if it sometimes hurts a bit, versus the person who frames everything as you're either with me or against me. You're either comforting me, or you're persecuting me. You're either fused with me or abandoning me. Those kinds of intense, not psychotic, but very powerful ways of experience things as dyadic, not as an internal thing you can look at, but as a dyadic phenomena between two people. I think that's the gist of what we've meant by people at the borderline. And the term really came from 3 different places. It came from people in private practice who were finding, everybody was trying out psychoanalysis, and they were putting people on the couch if they thought they were neurotic. And a minority of them started to get worse rather than better. It was too regressive. They developed very powerful transferences that they didn't identify as a transference. Instead of saying, you've been very nice to me, but I can't help feeling that you might criticize me the way my mother did. They come in and they say, bitch, I'm sick of you criticizing me. And they give you chapter and verse about how you've done it. That's, they're not crazy, and they're usually onto something, but it's a very different process from the person who's a bit higher functioning. So it came from people who were finding that the technique that had helped healthier people, of having them say everything, go deeply into their feelings, talk about the therapist, lie down, let it all hang out, they couldn't put themselves back together after these regressive sessions. And then it came from people in hospitals who would admit people that looked crazy, often when they had just experienced a loss. And they're a minority of the ones that they thought were schizophrenic. They discovered as soon as they were in a safe, boundary place, they stopped looking psychotic, and they began to be a kind of a management problem. Half the nurses were saying, this patient has a really special, difficult history. They need extra TLC. And the other half of the nursing staff were saying they need limits, they need boundaries, they need consequences, they're manipulative, and they're hating each other. And we were trying to figure out what's going on there. And then the third place it came from was psychological testing, where there was beginning to be this report by psychologists that people that they gave psychological assessments to There was a small subgroup where if you gave them tests like the MMPI or
Rorschach.
the Wechsler, the structured tests, they
Yeah.
look neurotic. But if you gave them the Rorschach or the TAT, the unstructured test, they look psychotic. So what do we make of this group that has all this problem with identity integration, but they're not crazy? I think that's still a much more useful way to think about borderline than what the DSM did. What the DSM did was to, when they lined up the different personality disorders, which was an afterthought anyway in the 1980s shift from DSM-2 to DSM-3. That's why they're at the end of the book. They trotted out the ones that were familiar and that had some empirical research on them. And the therapist on the working task force said, you can't just talk about personality disorders without talking about whether they're at the neurotic level or the borderline level, because we've learned that you work very differently with those groups. And they couldn't argue that there was no empirical data, because by that time there were studies of borderline patients. And they went to Gunderson's work, and he had worked with a steroid version of borderline patients. He ran a hospital. What he was concerned about is acting out and affect regulation and difficulty with repetitive crisis creation. That's not what a schizoid borderline person does. That's what a more extroverted borderline person does. But because he had done research, his criteria for participants in his research became the criteria for the disorder, and it became a type of personality, not a level of personality. And I've never liked that. I think that showed a very grave misunderstanding of what the clinical community had come to over decades of conversation and scholarly work and comparing experience. And if you're an academic who has contempt for that, you're not going to listen to it, but they really should have.
Well, that brings up the psychodynamic treatment manual that I think you were very involved in developing. How has that been taken up in the field at all? I mean, I think it's such an important work that.
Thanks. It's very uneven. There are some places in the United States that have never heard of it.
Never heard of it.
There are some places that routinely assign it. In New Zealand, if you want to get reimbursement for patients, you can use a diagnosis from the DSM, the ICD, or the PDM.
Wow.
In Italy, there was a movement to use the PDM rather than the DSM as the diagnostic instrument.
It's so much richer.
It failed, but it was interesting to me that there were enough people behind that there was a movement.
Yeah.
Then in some other countries, they've never heard of it. It depends on whether there was somebody who could translate it into a particular language, or it was done mostly by clinicians, although when Vittorio Lingiardi did the second edition with me, he is a clinician and a researcher, and he integrated a lot more research into it. So I think
it's a brilliant work. It's a brilliant work, and I think every clinician should have a copy of it and read it and know it. But what was it like for you to be involved in that? Was a large effort to put that together and to develop that.
Well, the first edition, that was Stanley Greenspan's baby. And I was just nominated by the president of my organization to be on the task force on personality.
Oh.
She knew my book. And as we worked on it together, it became clear to Stanley that I was a hard worker and I was a good editor, because he wanted to self-publish that to keep the price low, which I think was the wrong decision, but I understand why he made it. We lost the marketing of a publisher when he went that route, and the fact that he died unexpectedly 2 years after it was published meant
that was terrible.
It kind of died on the vine. But I ended up with Robert Wallerstein copy editing the whole thing, and I enjoyed it because it helped me integrate. It helped me learn about preschoolers, which was the group that Greenspan was most interested in.
Yes. Yeah.
and children. And in the revised edition, one of the nicest things that happened was when the first version went out, we had the idea of putting it out there and then getting feedback and then doing a better one. And I got this email from a guy in Los Angeles saying, you frame this as a biopsychosocial developmental document. You've got infants, children, adults. Where are the elderly? And we all on the task force looked at each other. There's Kernberg, there's Wallerstein, there's Schlesinger.
Here we are. Here we are.
80. And oh yeah, the old people. How did we forget about them? We were a study in denial. But in the second edition, we have a very interesting section. It's the first international classificatory document that takes up geropsychiatry seriously and integrates it with other developmental stuff. So it's to some extent, it was a burden. Translating Italian English into English was sometimes a challenge. I would get sentences like, the child suffered from wet bedding. But I believed in the project. And I don't make any money out of it. All the royalties go toward funding research that will be beneficial to clinicians.
What's so sad to me is Barbara and I have been doing a pretty extensive literature review for the chapter we're writing, and most of the researchers don't even cite it.
Yeah, I'm not surprised. I mean, most researchers now have drunk this Kool-Aid that, clinicians up until the 1990s or so knew nothing, and we're all lockstep.
Working by the seat of our pants.
Yeah.
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 Yeah. So let me ask you a different kind of question for a minute. You have, the more you talk, the more I can admire how much you've integrated and how much goes through your mind, the different perspectives and everything you talk about. If you were going to give a gift to those people watching of what you think is the most important thing that they could learn to do as a therapist that would help the most people, something very basic that everybody has to kind of do all the time. If you could narrow it down to something like that, or a couple things, what would you say?
What comes to my mind, I'm not sure it's quite the answer that fits the question, but I go back to the say everything. If I could give a gift, it was try to find a relationship in which you can be fully yourself, say everything, including the darkest areas.
Mm-hmm.
I think that was the genius of, for all the things that Freud got wrong, he learned from a patient, which says something about his respect, that it helped her to try to say everything, to free associate. And I do think that is, we don't usually now with our patients say, you must say everything that comes to mind and identify it when you find yourself not doing that. We say, try to speak as freely as you can here and let me know if you're having trouble speaking about anything. But I think that's the most healing procedure that people go through in psychotherapy, is trying to be true. It's a process of trying to be increasingly honest, which is a lifelong project, and none of us ever succeed in it because we all have our various ways of, kidding ourselves.
So if you think that, to what degree does that go for the therapist, that the therapist should be so honest and open?
Well, I think the therapist has to be honest. Open would be, how open I would be would differ based on my understanding of the patient. But I think therapists have to be internally honest. On the other hand, we all have blind spots. And I don't think it's legitimate to ask ourselves to be superhuman in that area. Our patients will figure out what our various lies we tell ourselves, and they'll let us know. And
Our vulnerabilities will be evident.
Yes, right. And I think we're more like, I don't think we have to be ahead of our patients either. I don't think our mental health has to be better than our patients, any more than the coach of a good athlete has to be a better athlete, or the coach of a good singer has to be a better singer. We just have to know how to help people develop their own ways of growing in the world.
So you don't think our mental health has to be better than the people we're working with?
I wouldn't make that as a general statement. I mean, I've known some really fine therapists who have struggled with terrible depression, for example. And I never have. I'm lucky that way. I would say they understand some things that I don't.
But would you say that a therapist should at least be at that neurotic level of organization with someone at a lower level?
That. I think Marsha Linehan would tell you she still had a lot of borderline qualities late in her life, and yet I think she did immense service to uncountable numbers of people by developing a therapy that, I mean, she was in that hospital in Oklahoma for God knows the umpteenth time, making a vow to herself that if I live through this, if I get past my suicidality, I will develop a therapy for people like me. And she did.
Yes. Thank you.
So, I mean, in a way, I believe that, but in a way, my senses tell me it's one of those ideas that feels foundational, but there are a lot of exceptions to that idea. And the idea that we all rank neurotic, borderline, psychotic is even an oversimplification in itself. If you stress me in enough different ways, you're going to see the borderline and psychotic parts of myself, even though generally I'm a pretty high functioning person. And if you work with psychotic patients, you find they have islands of extraordinary capacity that coexist with their dysfunction. I think therapists have to have a certain kind of heart more than they have to have a certain kind of mental health.
Mm-hmm. Yeah, I think you're right. I think that's the blessing of aging, and that you have to rely more on your heart as you get older. And
that's for sure.
I think it helps you do a better job.
Yep.
So you were talking about free association, and when I was in psychoanalysis, that was which I did for about 3 years on the couch, and I thought it was a most amazing experience to say whatever was on my mind and actually have someone listen to me, even though I was paying, was amazing. Like actually going to listen to me for 15 minutes 3 times a week, and it was a pretty profound experience. But I think you're so right, because I can see the uptake of that in my training in EMDR, which one of the things that we're trained to do is tell people, try not to censor, whatever comes up is okay. And it's really about giving, I think, having the freedom to let your neural networks fire in whatever way they can, which to me is about the reintegration and what Bruce Eckert calls memory reconsolidation, which is that firing of those networks, letting them see how they sync and link. And then I think it allows you to restructure and reorganize your neural circuitry.
Yep, I think that's what the neuroscientists are finding. And psychotherapy does change the brain.
Do you focus on getting certain pathways to fire, or don't think about that sort of
I
thing.
don't think about it. I talk a little bit differently than I once did. I mean, when I'm talking to somebody with trauma, I might explain to them why they might not be able ever to remember a traumatic experience that they have emotional memory for and somatic memory for. But I explain to them that glucocorticoids that get secreted during trauma sometimes shut down the hippocampus, and that's where memories are laid down in the first place. So it's not a matter of their being repressed. We were wrong about that. Many of them were never laid down. So I sometimes revert to neuroscience to explain things to patients. And where I might have said at one point, your id's in conflict with your superego, I might say now your amygdala is in conflict with your prefrontal cortex.
Yeah, no, I think that language can be very helpful to people.
Yeah.
Non-pathologizing.
Yeah.
Yeah. Yeah. See, I mean, in keeping with that theme of non-pathologizing, do you help them kind of become aware of the patterns that they're using and how useful it is to get to know those patterns and see how they reverberate throughout their psyche and their behavior?
Well, usually I find that if they can talk freely enough, they start hearing the themes themselves. I don't have to rub it in that do you see you do this in every situation? They start identifying it. And I think it goes better when it happens that way. Then they're not complying with you. They're letting you know. I also had a very powerful, positive experience in analysis very early. My life would be completely different without it. And I went into it, with all these defenses about how, well, this is just a professional thing that people do. I learned Latin before French, and I took classical music before popular. And so, I'll do what the old guys used to do and lie on the couch and free associated. It was profoundly helpful to me in so many ways that have put me on a whole different path. And I think a lot of it was just being able to say everything. And I noticed that when I talked about my analysis to people, I didn't say my analyst told me that. I would tend to say, I figured out in analysis that. So my analyst was very good at not needing to show me that he already understood more than I did about myself. He was very good at raising questions that I could then explore, and I could feel like I told him something that I discovered. And for a woman, especially in the era when I came of age, to be able to be that supported in telling a man about herself rather than deferring to him was profoundly important.
We have a couple minutes left, and I just could you say something about working with egocentric character, which is the people who are so identified with their defenses that, in my experience, the best stuff that I learned was when I got trained with Davinlu for working with egocentric character disorders. And they're not, I don't often get them, but when I do, those kind of more intensive challenging of defenses seems to often be useful. What's your...
that's where what Michael was saying would really apply. I do find that with those patients, I kind of have to hit them over the head with a hammer about, you're doing it again. Do you see that you're doing it again? There are people where the defenses are so powerful that you really do have to, in a way, you don't just analyze them or just mantle them. You have to go under them in a way and say, look, do you see what you just did?
Yeah. So we have about a minute left in our discussion tonight. Is there anything else anyone wants to add before we will stop recording in a minute, but we'll stay around. Anybody wants to stay around and talk, we'll talk for a little while and debrief. But anything else we want to add? Anyone wants to add before we sign off?
I think one of the things that I learned from this meeting today, besides a lot about our guest and her knowledge, but was that how subtle this use of language and in this kind of can bleed. There can still be misunderstandings that are profound, and I think that we have a, I can see there's a long way to go. I have a long way to go in terms of being clearer when I speak, because what I say is maybe too vague, and so I got an extra goodie here today.
Well, I want to thank you all for just asking me about how I work and not artificially trying to get me to defend my orientation or my type of I mean, this was a really just a pleasure to talk to colleagues. So.
Well,
That's great. It really is.
It was our
Thank you
pleasure.
so much.
Yes.
Thank
you. And
you.
thank you for everyone joining us tonight. This will be available as a recording for people who didn't get to see it. And we're going to stop the recording, but we're going to hang around and talk. If you have questions, and come back again.
Definitely.